Hopefully everybody's enjoying their lunch. Make sure to grab your coffee. Still have a good afternoon of good sessions to come. This is not part of the CME part of the course. This is non-CME part. And so I'll be talking about something. But before I get to that, I do want to acknowledge our sponsor, Carlsmed. They're one of our biggest sponsors for the conference this year. So, it's really important that we have these industry sponsors that help make this event possible. So I'd like to acknowledge them and give them a round of applause for their support of our event. And so, I alluded to this a little bit in my talk yesterday. For my minimally invasive spinal deformity cases, I use a lot of interbodies, and we saw that there was some data that there's some imprecision in the interbodies that are out there already, these so-called stock cages. And so there's a reason that I've transitioned my practice over to the applicable cases to these personalized devices, because it really lets you dial in your corrections. And this is an AI-enabled platform. It's both a surgical planning platform, but also a patient-specific device. And I'll talk to you about how it's actually shaped my practice, but also how I think it will shape the future of personalized spine surgery. We've been talking about personalized medicine to some extent for, about 2 decades. But now, I think this is the way we can achieve this well in spine surgery. Here are my disclosures. Of course, I'm a consultant for Carlsmed, so I'll be talking about their devices today. But to take a step back, let's talk about aprevo and their clinical goals. So aprevo is the platform for Carlsmed. And it's not just a device. Some people think, well, we have screws and instrumentation, we have cages, a cage. But this is actually an ecosystem. And we're talking about an ecosystem with a goal of reducing implant-related complications and revisions through improved surgical outcomes. And you can't do that, of course, without data. And so that's one of the most important things that Carlsmed has done, is they've actually gathered a group of their highest users, and they've actually started a prospective registry called the Compass Registry. You could see the sites here, a bunch of high-volume spine centers in the United States, and they've actually done an IRB prospective cohort, and they've looked at patients across 16 centers that are both getting short-segment fusions, but also long-segment fusions in deformity surgeries, and they've tracked their outcomes, right? They've tracked the alignment, they've tracked complications, they've tracked patient-reported outcome metrics, and of course revisions as well. And so that they now can answer these questions, are these devices actually improving outcomes as well? And the reason for this is, we've known the many benefits of these devices for quite some time, actually. Since December 2020, at that time, there was a lot of preclinical studies. There's biomechanical studies, there's finite element analysis studies, there's also cadaveric studies that show that when you have a personalized device, you can achieve your plan correction more often. You can decrease posterior rod strain because you have a stiffer construct. You can increase the contact area for your specific end plate. And then because you have a good fit to the end plate, you can decrease end plate stress concentration and then have more effective contact as well. Avoid something we call point loading when you have a cage that just rests on a very small portion of the end plate. And because of all these initial preclinical studies, the FDA actually acknowledged this and actually granted this a designated breakthrough designation. And this is important because it's allotted this to have, certain regulatory and marketing and also clinical, advantages. And this is, again, by the FDA. And so this has been implanted since December 2020. I was actually in the first case of ever this cage being implanted at UCSF. I'm actually the assistant here. And this is actually putting in an ALIF cage. This is a video from that, and you can see the time of 2020. You can see my N95. I really hated wearing that. But there you go, just to show you the evidence of what time that was. And now, because of the Compass Registry, we have a lot of the clinical data that's important, right, to show the many advantages of these cages as opposed to stock cages. And I won't go through all the percentages now because I will go through each of these studies one by one. But just to highlight some, emphasize some points, that we have now 80% of intersegmental lordosis, we can hit a targeted alignment at a given level. That is so much higher than with stock cages, in which you have such a disconnect between the degrees of that cage you're putting in, what actually intersegmental lordosis you're actually achieving. And I think, of course, it's all fun and nice to get the alignment correct, but what does that actually mean clinically? Well, I think that bottom level here is the most important thing, in that we can actually decrease the rates of reoperation because of these sorts of cages and getting that alignment right. So much so, this is recent Scoliosis Research Society presented data this past week that it's decreased reoperations up to a rate 25% of the number of reoperations, from 16% down to 4.3% for adult spinal deformity cohort. So very important stuff here. So the first thing is, I often get the questions from a lot of surgeons is, okay, I get the case use for big deformity surgery, but why does this matter if I'm just doing a 1-level or 2-level fusion, right? The bread and butter that we have in the clinic, right? Most of us are doing an L4-5 fusion or an L4 to S1 fusion. That's the bread and butter. So why does this matter? I'm just going to shove some cages in there. Patient's going to do fine. But we know that actually they don't necessarily do fine unless you're paying close attention to the alignment. These are some seminal studies, especially for the trainees, you should know these two, but one of them is that actually if you don't hit your pelvic incidence lumbar lordosis goal with just a 1 or 2 level surgery, actually you have a 10 times higher rate of needing revision surgery. And actually this has now been borne out in large meta-analyses as well, as if you don't hit your sagittal alignment parameters, even with a single segment surgery, you're having a much higher rate and much more rapid development of adjacent segment pathology. So this even matters in small fusions. Now, it is challenging, to be fair, right? Achieving the optimal alignment is not easy, and there's different rules, there's different tensions when we're thinking about surgery. The first thing we're thinking about is we can't create malalignment. Let's avoid that. And the next thing is, well, let's do something to help prevent adjacent segment disease, whether that be MIS, so we're not exposing the other facets, or that means we're not overstuffing the cages. There's a whole host of things we're thinking about for that. And the last thing is, why are they having back pain? Well, it's because their spinal alignment parameters are out of whack. And so we need to fix that, right? And that will help their back pain disability. So you can see that there's so many things that go into planning for a given surgery, so that one, the planning is complex, but then even the executing on that plan is increasingly complex. So we need certainly tools that can help us in this regard. The other thing, and an added challenge as well, is that we can think about how stock implants don't totally conform to the end plates of a given level, right? Vertebral body end plates aren't flat. They have bumps, they may have concavity, they may have a convexity. It's really more like a fingerprint than something flat. And so that if you're putting a certain cage in there, and this is the data actually on the left over here, like a 10-degree cage, on average, maybe in this study, you're getting 2 degrees actually at that segment. Or if you're getting a 12-degree cage or a 20-degree cage in this HSS study, you're actually getting only 2 degrees or 3.4 degrees of lordosis. So you can see there's a big disconnect between the actual cage lordosis and the lordosis of that segment that you're actually achieving. So this is where the benefits of Carlsmed and the aprevo platform and the cage that they designed can come in. And you can see here, this is a schematic, of course, just an illustration, but I think it's particularly powerful because you can see, for example, if you have a trapezoidal L4 vertebral body like this, and this is not uncommon in scoliosis, that if you were to just put in a stock cage, that there'd be that huge gapping. You would not be able to horizontalize L4. It would actually still be wedged, and the patient would not have their coronal plane corrected. As opposed to if you 3D print to that negative space, they actually have a cage that can fit that coronal wedge, then actually you can horizontalize L4 reliably, which is often a goal for our surgeries. This is other sobering, issues, right? This is something I presented yesterday in my talk when this is a study that we wrote out at the MIS ISSG. And when you're using multiple levels of these stock cages, this was lateral lumbar interbody fusion, that actually 28% of patients that were previously aligned, so these are all aligned patients at baseline, could become malaligned. So it's clearly a major issue and we need to be improving. And so they've now first come out with their COMPASS study showing that you can hit your predictable alignment. So this is the study in which they had looked at 365 levels, 217 patients were included. And they looked at both A-lifts, laterals, and T-lifts. And actually 82% of patients were able to be within 5 degrees of your targeted intervertebral lordosis. And only 10 of those 365 levels exceeded the target lordosis by 10 degrees. So you can see that you're able to now have more pinpoint precision in getting your intervertebral lordosis, things we weren't seeing before for those studies that I just showed on the other slide of how off the intervertebral lordosis is relative to the stock lordosis measurement of that cage. The other thing is, how does this matter for our smaller segment surgeries, right? Again, this is the bread and butter. This is saying, well, why does it matter? If it's an L4-5 fusion, I'll just put a cage in there, maybe no cage, and then that patient will be flat, but they'll be stabilized from their spondylolisthesis, and they'll do fine initially. They'll be happy. They'll come to clinic at the 6-week appointment and say, thank you, I feel great now. But why does that matter? Well, one is when you use these stock cages at just a 1 or 2 level fusion, so this is a study of just 1 or 2 level fusions, if in this cohort, 30% had malalignment preoperatively. After the surgery, 30% still had malalignment. So basically, they weren't doing any better after the surgery. And in fact, in the patients with pre-op malalignment, 70% remained not corrected. So one, you can see that stock cages don't do a very good job in correction. Now, on the other hand, with a similar cohort, so the COMPASS registry looked at patients that only had 1 or 2 level fusion, that when you used a patient-specific cage that was designed to the lordosis you want, to the end plate topography that you had a 52% increase in alignment restoration and a 21% decrease in cases in which alignment was not restored. So these are doing better. The other thing as well, if you listened to Pete Angevine's talk yesterday, is there's this new notion of the lumbar distribution, the lordosis distribution, and that it actually matters where the lordosis is as much as how much lordosis you have. We've known for a long time that lordosis should match the pelvic incidence, but it actually needs to be mostly from L4 to S1. And then the upper part of the lordosis, it will depend on how much pelvic incidence you have. And so the issue is actually if you don't hit the right distribution of lordosis, you have issues. So this is a study in which they looked at 149 short segment fusion patients, and they showed that when you use stock cages in patients that have a hypolordotic distribution or a hyperlordotic distribution, right? So when they weren't distributed well at baseline, actually most of these patients worsened by about 5% after surgery. Also, if you had hypolordotic lordosis distribution after surgery, you had a much higher rate of needing revision surgery at 1 year, with a 1 year revision rate of 20%. So that means 1 out of every 5 patients in this cohort is getting surgery that didn't have the right distribution of the lordosis reestablished. So again, it just goes to show how important that is. This is a case that came to me from NYU that I think drives this point home, right? This is a classic flat back cascade. We're seeing this case in everybody's clinic throughout the United States. Right, you have a small fusion. What could go wrong? L3 to 5, I'm just treating 2 levels. We'll put some cages in there. But look how flat that is, right? There's small fusion, no lordosis. And then you classically then get the cascade that happens next. The patient will compensate. They're smart. They're not going to feel this at first. They'll have a retrolesthesis at the levels above with the compensation. They'll have hyperlordosis trying to get their lordosis back into alignment despite how flat the bottom of the spine is. And this whole time, especially for this patient, he's a low PI patient, actually the overall PI-L mismatch is not that bad. But because of how maldistributed that lumbar lordosis is, the patient gets a very rapid development of adjacent segment disease. And you can see that I had to take this patient for a minimally invasive deformity correction from T12 to pelvis to fix that problem. Maybe I wouldn't have had to do that if the index surgeon had gotten the alignment correct the first time. So this is something that the aprevo cage can help with. It also can help with distribution of the lumbar lordosis, right? Because you can dial in the exact lordoses you want at different areas, you can make sure that it's optimized from L4 to S1, you can back off a little bit from L1 to L4, and you can get that lordosis distribution better. And they've shown in the COMPASS registry that they are able to achieve this in those 1 to 2 level fusions. The reason why this matters so much, too, is this is a particularly bad study. It was actually interesting that of their 335 patients that had lumbar fusion, this is stock cages again, that only about 10% of patients in this cohort were able to be reestablished to a normal distribution of lumbar lordosis. And so they compared the patients that got reestablished to a normal lumbar distribution versus those that did not, and they had a much higher rate of reoperation if you did not have that distal lumbar lordosis reconstituted, up to 20% versus a 7% 2-year reoperation rate. So again, a 3 times higher reoperation rate when you weren't reestablishing the distal lumbar lordosis to how you needed it. However, in an aprevo study with the same sort of cohort, when you actually use this cage, again, dialing in that L4 to S1 distribution of that lumbar lordosis again, they actually had a 630% increase in the number of patients that had their distal lumbar lordosis reestablished. And so, again, this cage offers that opportunity to really dial that in. The other thing that really matters is we've been talking a lot about short fusions. But again, a lot of us are doing deformity now. A lot of us are doing long fusions. And it's very important to think, okay, what are the revisions that are happening for these long fusions happening for? This is an ISSG study that looked at almost 900 patients that had revision surgery, and the number one reason for reoperation was due to mechanical complications due to X-ray malalignment. So you see that if we can fix that malalignment, we should be able to actually treat at least a good proportion of these reoperations. And here's what it looks like here is another, combined with this data, which is very important that I want to emphasize here, is that these are ISSG surgeons in this study, and what they had them do is they actually had them plan for a given surgery what PI-L mismatch I want to get to. And then they had them execute on that plan, and then they looked at how close they got to that plan after surgery. And again, these are some of the best surgeons in the United States. And actually, only 31% got within 5 degrees of their plan. I mean, that is so low. There's no other field where that would be acceptable. That, okay, I have this, I'm going to have this plan, and I'm not hitting it more than 2/3 of the time. And in fact, the PI-L goal was more than 15 degrees off in about 1/3 of the patients. So they're really off, right? So, this is another thing that the aprevo can help with. And this is actually a subset analysis of the ISSG patients that had the Carlsmed patient-specific cage, and you can see that actually there's a 42% increase in the cases within 5 degrees of the planned PIL mismatch when you use the cage, and a 50% decrease in the cases in which you had that big miss, that PIL mismatch greater than 15 degrees. So you can see that there's much greater improvement in alignment after this kind of surgery. The thing I'll end with as well here is revision rates, right? Because ultimately, we can talk about alignment till we're blue in the face, but it matters what that actually leads to in the long term. And it's revision rates, right? We don't want our patients having to go back to have more surgery. And we know that after adult spinal deformity, there's quite a high rate of reoperation. In fact, these are some of the main studies and some of the largest series we have, anywhere from 16% up to even 30% reoperation rate from a host of things, right? PJK, PJF, rod fracture. But actually, when you use aprevo, and this is brand new data, it's going to be published soon, but actually was just presented at the Scoliosis Research Society meeting. They could actually decrease the reoperation rate at 2 years from 14.4% down to 3.5%. So only a fraction of the reoperation rate when you use the aprevo cage. This is actually how it looks stacked up on this column graph here. It will be published soon in the Global Spine Journal. So I actually wanted to take a time to step back and actually show you how this actually works, because I get many questions, especially as my colleagues are starting with the aprevo journey at their other institutions. How does it actually work? And they think, oh, it's just this cage. Do I tell them, what do I do with this cage? How do they even print that? And so I'll tell you actually how it works from start to finish with one of my cases. And so the first thing is we have this aprevo technology platform. And so it's really a planning software platform. It's something you can have on your iPhone, your iPad, or your computer, and it helps you visualize the spine, helps you manipulate that spine. And then once you actually manipulate that spine into the way you like with certain measurements that you want in terms of lordosis, foraminal height, posterior disc height, then you can accept a plan, and then a 3D printed cage is made to that negative space of that plan. And so this is that 3D printing, that's a step. And then afterwards, after you put these cages in, you actually then get a postoperative report. They actually pull the x-rays from your hospital, and you can see how well you did, how true you were with your intervertebral lordosis, how true you were with your coronal tilt, and you can see the delta between your plan and what happened in the real world. This helps because, one, you don't know if you're doing well if you're not measuring it, but two, then if you see something consistently inconsistent, then you can say, well, I need to change this or that so that you can further iterate and improve your outcomes. And the whole goal with this is that you have this seamless end-to-end ecosystem from the consult to the CT scan, to the app, to the approval stage, to the printing, to getting your intelligence report, and going back so that you can further improve. Now, the first thing I get asked is, how hard is that? I mean, it sounds like a lot of work. I'm already busy. I'm seeing so many patients in clinic, doing research, giving these talks. I have medical students to work with, yada, yada, yada. I don't have time for this. But actually, it's pretty straightforward. And at least if you're like me, I don't do a fusion unless I have a CT scan. So that's all you need. And I have this fine-cut CT scan for all my patients. And then the only thing you need to do actually for your vendor is you just alert them that this CT scan has been done. And then they actually have a back-end system which they work with the hospital to pull that scan for you. So actually, that's all you need to do. There's nothing else that you need to do from your back-end from your hospital. And so let's walk through this case. So this is a patient of mine with scoliosis, severe back and leg pain. She's both in the positive in the sagittal plane, also positive in the shifted to the left in the coronal plane. And she has not the best bone quality. She has multi-level spondylolisthesis, which again, you know that means that there's more degeneration going on this spine as opposed to someone that doesn't have that. And as well, she has multi-level stenosis worse at L3-4 where there's severe stenosis. Some of the things you can see here, and if you recognize this from yesterday, I talked about it because of that L2-3 osteophyte. There's also an L5S1 osteophyte. And this is a very important point here because this is not a black box system. You do interact with the engineers for the system because they need to know what you're going to do to those levels, right? At L2-3, maybe you'll just leave that there. You'll leave the osteophyte, which is very reasonable, and then you have to plan cages for that correction, or you'll leave 5-1 like that, right? Or are you going to correct through there? Well, you know, open those up with an osteotome or something, and then you can plan accordingly to that. So that's the first thing. You talk to the designer. There is an interaction and a communication through the app of what you actually want to achieve with this surgery. So that's the first key here. You know, of course, there's a lot of patient-specific inputs for this. There's, of course, the end plate topography of the patient. There's the lordosis of that patient. There's a pelvic incidence you're trying to match, and they use a means parameters for what we want. That's one of the major studies we have of what lumbar lordosis goals we should hit. These are patient-specific, inputs, but there are surgeon-specific inputs, and that's very important here too. Every surgeon's a little bit different. For example, for my A-lift cages, I always want at L4 to S1 to have an 8 millimeter posterior height. For my lateral cages up higher, I want a 6 millimeter posterior height. That may be different depending on the surgeon. Also, where you're going to place these cages differs on the surgeon. So these are all the surgeon-specific inputs that matter that they'll refine, and once you work with them a couple times, then they'll understand, and that'll be kind of the default. But until then, there is a lot of interaction to get your specific preferences down. Now, the next thing is once they know those preferences, then one of the platform's key points of the platform and one of the things they can leverage is they have this large database of over 2,000 CT scans that they've annotated, and so that they are able to use their AI to then, one, identify the vertebral bodies for a subsequent CT scan you're getting, auto-segment that, and then actually move that around and manipulate that. So that's the key. That's one of the key features of their platform. And then based on all the predictive analytics from prior studies and also your patients and also the inputs you give, they're able to create a 3D model for your patient at baseline, but then also for that correction that you want. Then once they actually move the bones of the spine, then they 3D print these cages to that negative space. This is how it actually looks, the aprevo app on your iPhone. This is the way I actually interact with the platform. So you can see that there's a screen with measurements. You can see that you can look at the patient's x-rays and reference that as you're designing the plan. You can see, again, how the model looks like when you're, I put the cages in or without the cages. You can decrease the opacity of the vertebral body so you can see exactly where is this implant located. And actually, you can make these screws very specific. You're not limited with the 5 millimeter differences in the screws. So if you're someone that wants to do standalone A-lift cages, actually, you can dial in exactly a length that'll be perfectly bicortical on the back of the posterior cortex without violating the canal, depending on where you're going to place that cage. So these are all things you can dial in. You can also look at the measurements at each level. You can further refine that based on different things that you care about. And then so this is how that looked like for this particular patient with the scoliosis that I had shown. You can see these models that, of course, they look nice, but the important part is the measurements that come with that. And you can see, for example, at the lateral levels, you get a lot of data, right? You can see what it's going to do for the intersegmental lordosis. You can see what that actually looks like relative to S1. You can see the coronal tilt at each level. You can see the anterior height that's predicted with this cage and also the posterior height that's predicted with this cage. And so you can make sure that it meets your goals. So, for example, they know at Carlsmed now that I want about 6 millimeters for the posterior height at L1 to L4, and 8 millimeters of posterior height from L4 to S1. That does change a little bit depending on how much central stenosis or lateral recess stenosis there is, because I may try to overstuff to get more indirect decompression for central and lateral recess stenosis in those cases, and so that's going to be a little bit different. But again, that's some of the surgeon inputs that happen. That's the lateral cages up there. Here are some of the A-lift cages at the bottom, again, with some of those specifications. Again, one of the points I drive home is oftentimes without interbodies, we're left with this tension between intersegmental lordosis and foraminal height, right? Because to get a better foraminal height, we're really crunching down on the back. And even with some of these stock cages, there's this new concept of this hyperlordotic stock cage, which means a 30-degree cage. That often that means you can get 30 degrees at L5S1, but the height of the posterior of that cage is often 4 millimeters. So you're creating iatrogenic stenosis. But with the aprevo platform, you're able to optimize actually both segmental lordosis and that foraminal height at the same time, so you can still keep that 8 millimeters of height posteriorly, which I always have as a requisite, and get that 30 degrees or what have you that you want at L5S1. Then after you approve the plan, you actually press this button, the cages go to production. And so actually, when I first started, it took about a month, and actually now they've gone this down to 10 days, and based on communications, this is going to be even faster than that. They're actually having more 3D printers in the United States. I think the next one's going to be in Florida, so for us in the Northeast, this is going to be even faster. And then so they 3D print these cages, and the thing that I didn't mention before that's very important is they actually give you the opportunity to print a plus-size cage and also a minus-size cage too. Now, again, more than 90% of the time I'm using the plan cage, but it's important to have those other options because, for example, let's say the facet joints are ankylosed and you think you can pop them open with trialing, and you can't. Well, you can't just shove the big cage in there. You got to use a smaller cage at that point. Or on the other hand, if you're having, let's say our intern that's trying to prepare the disc spaces and then they bust up the end plate, well, that plan cage size isn't going to work anymore. And so then you have to use a plus size cage, right? Or there's a whole host of other things, right? If you have the inferior vena cava that you think you're going to be able to dissect off for that L4-5 A lift, and you can't, then you may only have half the disk space exposed, and you're not going to have that nice side-to-side view that you need to place the cage. So you either need a smaller size, or you even either have your vendor even have some stock cages available in that scenario. But this makes you very nimble, and they give you that opportunity to have a negative size cage and a plus size cage as well. So intraoperatively, of course, you get each of these cages, and they're all peel packed. So you basically, I have them actually stuff the planned cage with BMP and allograft before. It actually increases the efficiency of the operating room, right? We're always trying to, decrease the anesthesia time, decrease the time in the operating room, have better throughput, as you saw from Mike Wang's talk yesterday. This helps you do that, right? You can get our ALIF placements down to 7 minutes now because you know exactly there's 2 trials that will go to the size that you need. You don't want to over trial because you need to keep the end plates intact, and then you're putting in the cage. And so that's key, that you don't need to plan, where am I going to put this? Do I have to put this cage more asymmetric because I want to tilt the vertebral body this way? These are all things you think in your stock cases. Or I'm going to have my vendor measure the intersegmental lordosis with this stock trial because I'm trying to get about 30 degrees. So how does that look? Okay, maybe let me take a step down. There's all that imprecision that you can avoid with this cage. And so that correction is built into the cage, which is very helpful. The other thing as well is you get these iPads. So I have my vendor have these iPads in the surgery. And what's important is then you can make sure that you're really true to what you planned. And so what I have is I have them put the lateral shot up on the iPad, and actually, as I place my cage, I'm referencing that. I'm referencing exactly where that cage should be placed. This is one of my cases for an L5-S1 ALIF. This is a different patient than the patient I'm showing you with a scoliosis. You can see, boom, that's the location that I want that cage. That's what I planned for. And so I'm going to leave that in this location right there. And you can see you have a good long-term result. The other nice thing you can see from this cage is, again, look at the end plates here. At S1, we typically have this convexity. L5, we often have this concavity. So if you just put in a flat cage in there, it's not going to touch a lot of that end plate. And so you wonder, you don't have as much biomechanical stability, and you're also asking the bones to fuse across this huge gap. I mean, it's not going to happen. This is why this is such a biomechanically more strong construct, because you actually have that end plate contact the whole way through. So this is going back to the case. First day I do stage my surgeries again, so I put in my ALIF cages and the lateral cages on one day. You can see already you get a very good correction in the sagittal plane, and then you get about a 50% correction in the coronal plane in this case. And then you go into the stage 2 day. And one of the things that's very nice about the aprevo platform is I also use the patient-specific rods that Dean had talked about earlier today. And actually, I can feed the exact cage measurements I have from the aprevo platform into the unit platform, and so that they can actually 3D print a rod that's specific for that spinal correction I designed. So you can see how this is very important. It's a whole ecosystem. And then so when I'm passing that rod into these percutaneous pedicle screws, as I reduce down, it'll further conform to that spine. And that's how you get that last bit of 3D rotation for that scoliosis, so that you saw there was a little bit of coronal cob left, how you fully correct that. So in terms of post-operatively then, when you're done, you get a lot of data, right? Of course, you get the X-ray films, which are very important, but you get the pre-op, the plan, and the post-op measurements, and you also get the delta, so you can see how true you were to your plans. I'll go over that in detail in a second. You can see I do get an intraoperative film to always make sure we're in the right, we're getting the right correction. If you ever need to do anything, some minimally invasive osteotomy or something, this is your time to fix the issue, but that's never been an issue yet. I haven't had to at this time. And then you can see in terms of our post-op film, our standing film, that we have a great correction both in the coronal and sagittal plane. And the nice thing is then you can always look at how much did this recapitulate that plan that I had. So you can have this schematic. You can look at how that CT scan looked, that illustration you had in your aprevo app. You can see how closely that conforms to your post-operative standing X-ray. You can see as well how that conforms to your post-operative sagittal view compared to your sagittal CT. And you can see that it does a really good job. And then ultimately, you want to get down to the nitty gritty. So you can go segment by segment and see how well you did. And you can see here that actually we're very close, within 2 degrees at most levels for the intersegmental lordosis. And what's very important is we're very good at the coronal tilt in each of these levels, right? We're not doing something unexpected in the coronal plane. And then also, on average, our posterior heights are reestablished to exactly what we want, within a couple millimeters. But most importantly, as well as these regional letterments, right? Regional measurements, PILL within 1 degree of our plan, L4 to S1 within 1 degree of our plan as well. These are things that are very hard to do without these sort of templates, right? I mean, I told you yesterday, for those of you who weren't here, I mean, there was an ISSG member that said at a recent deformity conference, we need to create a manuscript for how to do these surgeries. And then people were already arguing of, what the best way of this and that is. You could just see the imprecision there versus if you have something like this, it gives you the template to paint a Mona Lisa. It makes it a lot easier. You also can get aggregated reports. I like looking at these reports. You can kind of see how you're doing, what kind of surgeries you've done so far. So this is the aggregate data analysis. This is at a time when I only had 52 levels. I actually just did my 100th level last Monday. This is for that cohort of patients. You can see there's a good smattering of some deformity patients, some degenerative patients. You can see the number of interbodies you put in. You can see I don't put in any T-lifts. These are all A-lifts or laterals. These are, you can see which time point the x-rays were gotten from. You can see if the patients had prior hardware. You can see I had some upper thoracic cases, some lower thoracic cases, some lumbar cases. You can drill down a whole host of things, but it's very important so that you can see what's going on. But I think this is some of the most important data and some of the most impactful data, these scatter plots. So on the y-axis, of course, is the postoperative measurement, and then on the x-axis is your plan. And so this is intervertebral lordosis. And you can see that 94% of my levels were within 5 degrees of the target intervertebral lordosis, which is pretty amazing. And then in terms of the coronal angle, we're doing even better. 98% of patients were within 5 degrees of the coronal angle at each level. So again, we're able to plan something and actually hit that goal. Pete told you all the things we're talking about in terms of the measurements, and we're going to talk and argue about those things till we're blue in the face. But if you can't even hit what you plan to hit, then why does it matter what those measurements are? Why does it matter that we were saying now T1PA, L1PA is the most important thing? So that's why at least you have to be able to hit what you set out to plan to hit. These are some other graphs showing that your plan to post-op improvements are stable. And then this is some global alignment measurements. So this is L4 to S1 lordosis. And this is that thing, right? That key, that distal lumbar lordosis you need to hit to help to avoid reoperation. And you can see that 100% of my cases had this within 5 degrees of target. And then you can see in terms of the regional lordosis, so this is L1, S1, I get 95% within 10 degrees, right? So that's very important. Now, again, this is a little bit more difficult to hit, right? Because I'm not instrumenting L1 to S1 every time. Sometimes I'm just instrumenting L4 to S1. So there's a little bit of compensation, a little bit of prediction of what's going to happen to the rest of the mobile spine. But you can still see with that, we're still able to hit almost 95% of cases within our target lumbar lordosis. And the last thing that I really want to drive home is this lumbar distribution index, right? What I was talking to you about how L4 to S1, we need to have a certain lordosis there. We need to have a little less L1 to L4. And if you don't have that right combination, that it's an issue as well, right? Even if you have the right lumbar lordosis overall. And you can see that for all my patients that were preoperatively having hypolordosis from L4 to S1, I was able to move them back into a normal lumbar distribution. That's every single point there. For my hyperlordotic patients, they all went back to normal alignment. And then all the normal patients were kept normal as well in terms of their distribution. So we're, again, keeping these patients where they should be. We're improving them back to that normal lumbar distribution as well. And this really, I hope, drives home how nice this whole platform is in terms of having this iterative planning, this iterative feedback, and then you can now employ, let's say the next time you're planning for something, oh, I've noticed that at L3-4 this is happening, or L2-3 this is happening, and then you can change and see how you're doing, making sure you're following your data, because if you don't follow your data, then you're not going to be able to improve as well. And this is what it's all about, right? So again, this is a planning, executing thing. It's not just the cage. Oftentimes they get these conversations that this is just a cage, why does it cost this much, this and that. Well, this is a whole ecosystem to make sure that you're getting your one planning. Some people that don't even plan, not any of the surgeons in this room, but you're planning, and then you're also executing and achieving that plan. And this is what aprevo helps you do with, one, now data showing that you're hitting those alignment targets, but then two, that you're actually decreasing the number of reoperations because of it. So thank you. I'd like to take any questions you have about this technology.
Great talk. The two questions I have are, number one is, what do you do if you're trying to get some correction and the posterior facets are completely ankylosed and the thing's not moving for you? Mm-hmm. Do you change the interbody and put it something different, or do you still try to fit it in there even though you had planned for some correction, but that doesn't happen? And then the second question is, do you use patient-specific rods as an adjunct to these? And do you see a role for that, or is that critical, or what are your thoughts about that?
Yeah, so the first thing is that was actually one of my first concerns before I ever started with this technology is what happens, we know there's a whole spectrum of how the facets are ankylosed at the back from, completely fused to, it looks like it's very stiff. You have those osteophytes that are capping over. How well is this doing to, one, are you trialing enough and then to get that cage in there? And so one of the things I've actually been surprised in, first of all, is that actually a lot of those times that I think the facet joints are going to be too tight, actually it's not. And one of the things I've learned is with slow trialing and also with aggressive osteotome use at the lateral aspects of the disc space from the front, that actually if you completely loosen up the ankylosis of the disc space, that's pretty powerful already. And I've been able to overpower those facets in most cases. Now, of course, if they're completely fused, like from a prior fusion, then we're talking about a different scenario. But I think what you're asking is about those cases where it looks pretty ankylosed, and how do you know if that disc space is going to open up? And so actually I've been surprised, but one, it does take, you not turning your brain off. That's very important. So, you're not just putting these cages in, you're still putting them under fluoro. And if you ever see a disconnect between the trial that you need to put in to the cage that you're going to put in, and you see that that's not fitting well, then you're not just going to go to your planned cage. You know that maybe I have to use that minus size cage. Or one case in which I had a revision, TLIF, it was pretty ankylosed. I thought I could overpower, and I couldn't. And then I actually had to, even though the minus cage was too big, I had to use a stock cage. So that's why I have the stock cages available. That was one time, though. So you just have to be nimble. I think you have to be ready, make sure that you're not overdoing it. The most important part of this is you're not going to keep your plan, and it's not going to conform well if you bust up the end plates. So again, you can't overstuff. If the facets aren't letting you put in a bigger cage in there, you don't want to overdo it. So that's a great question. In terms of the unit plan, yeah, so I actually use both together because, this is one aspect of the personalized plan I have for these patients. And the other part is the rods. And that's how you can get these deformity corrections pretty much to a T because you're able to have this thing that's perfectly designed for the patient. Also remember that I'm passing this rod from T10 to pelvis or T9 to pelvis. And so if you don't have something that's perfectly conforming to the correction that you want, one, it won't fit well. You might pull out the screws. But two, as part of this is 3D rotation. And if you're not having that rod with the plan that you want, then you're going to rotate unexpectedly in that 3D plane and not get the correction either coronally or sagitally that you want. So that's why it's very important to actually have them crosstalk. It's very important that I have their aprevo plan. I always plan the cages first. That's the most important part of the correction, getting that lumbar lordosis right. And then I feed that plan exactly into the unit platform. And so they have the exact posterior height. They have the exact lordosis at each segment. And then they're able to make that rod that really fits like a glove in these. So it's really the two of them together that help me do my MIS deformity surgeries. You can, but I always use the custom rod, and it has taken iterations to get it perfect, and now I know exactly, and they know where I put my screws for these MIS deformity cases. I put them in the exact same place. The residents know how anal I am about exactly where that has to be. It can't be 1 millimeter off to this side or this side. It has to be floating this far off the facet at L4. It has to be floating this far off the facet at L5. It needs to be this medial or lateral at L5S1, and it's because these rods are made with that. If you obviously with navigation, you could put screws in a whole ton of places, but if you put them in a place that's unexpected, then you're not going to be able to rod appropriately. So it does take that recognition. So having said that, if you do want to use a stock rod, you can. So some people, to make it easy, they kind of don't put the screws as deep in the middle of the lordosis, and they keep everything pretty shallow so that it's pretty straight in terms of the screws themselves, and they pass a pretty straight rod. That's something you can do, but I don't do that. All right. Well, thanks, everybody.